Each one of you, whom we warmly welcome to the table, will have 20 minutes for your remarks, and then we'll have the question and answers with the committee members towards the end of your presentations. And subsequent to those question and answers, we will convene a reaction panel where each panelist will have 15 minutes each, and we'll hopefully open the floor again. So thank you once again for being with us. And with that, I'd like to give the floor to Pierre Barker.
Thanks very much, and it's really a great honor for me to be here. So thank you very much for inviting me. And I'm very fortunate that there's just a wonderful conversation that just happened, and thanks to the sponsors for raising a number of the issues that I am planning to raise, but will allow me to kind of move more swiftly through them and maybe dwell on some other topics. So my hope is that my focus will be more on talking about the issues of quality implementation rather than quality itself. So I think quality dimensions were very well described back in 2001. And I think what I see in my journey in trying to improve healthcare outcomes is really the task of trying to make healthcare more effective, make it scalable, and make it sustainable. And buried in here, particularly in effectiveness, I see the 6 dimensions of quality. So I'll be talking mostly about effectiveness. Joe will talk about scalability, but I will also reference a program as an illustration of the importance of a planned scalability. And then I'll just end off with a reference to sustainability, because I think it speaks to a model of development that I think is emerging and is really important in this conversation. I had the good fortune to spend a few months at the WHO, and every day on the way into work I passed this etched piece of wood, and those of you who've been to Geneva have probably seen this, but I think it's a very eloquent and simple description, I think, of what we're trying to do, which is a description of attainment by all peoples of the highest possible level of health. So it's the concept of full scale and equity and the highest possible level of health as a kind of a guiding light. So I think it already addresses 2 of the topics that were discussed earlier on, the fact that you cannot have access without quality. So it's kind of surprising that from the WHO in 2010, when the whole universal healthcare coverage topic was really brought to the fore, that this graphic emerged, which really focuses on who's covered, what the costs of coverage are, and what the services are. And I think one of the biggest illustrations of the clear gap in what wasn't there was given to us by this event that took place in India, where many of you are probably familiar with the conditional cash transfer program that was happening in a number of states in India in the 2000s. And what you can see here is the extraordinary increase in the number of women who are accessing care facilities to have their babies over this period of time. And this was being driven by the conditional cash transfer program, demonstrating that it's certainly possible to drive women into facilities. But I think the graph on the right, the simultaneous data on the right, I think is extremely important, which shows that there's really, in this environment, almost no effect of driving women into the healthcare facilities. So I think it's really, if you dislocate access from quality, you may not get any change in performance. I think that's the biggest message there, and I think it's been made a couple of times. And so it's no surprise that I would prefer a diagram which really has this 4th dimension of quality care included simultaneously. I don't think you can separate the 2. So that's the sort of the first and most important point. So if we just go through the 3, what I think of as the 3 dimensions of quality implementation, the first is that it should be effective, which is implement the dimensions to the as the WHO describes, the highest possible effect. Secondly, a design that can be adapted to context. We heard quite a little bit about context earlier, and scaled up rapidly within available resources. There's quite a lot in there. There's context, there's a quick time frame, and then there's the available resources. So there's this issue of scalability. It's not good enough to produce an effective pilot. We believe that there has to be a design of scalability, and Joe will talk much more about this, that is intrinsic to our efforts. And then the third, and is becoming really very much increasingly important, is this issue of sustainability, which we see as the capacity and the capability of countries themselves to design, implement, and scale up, and then sustain priority programming. So there's this idea of priority topics which came up earlier as well. So these are the three dimensions that we think are so important. This algorithm has already been described, and it really is a breakthrough because a lot of the efforts towards quality have been so much driven through inputs, and not enough attention has been placed on processes. And I think, as Kelly was pointing out earlier, really not enough attention now currently to outcomes. But still, it is a very important way of thinking of quality. I would argue that Donna Bedian left out a specific reference to context. And I'll just want to take you through a very small example just to illustrate what I'm talking about. So I visited this district hospital in Malawi in the middle of winter 2 years ago, or last year. And this is one of 13 hospitals that we were working with to try to improve mortality outcomes for small babies and for mothers. So this is the story I was told. This mother was admitted after a 20-hour labor. So she'd labored for 20 hours and arrived and was admitted. After a further 8 hours of labor, a baby was born with moderate asphyxia, was resuscitated successfully, but then required oxygen and transferred to a nursery. Then there was a power outage in the early evening. A backup generator was activated, but it ran out of fuel within 2 hours. The power failure resulted in the failure of the oxygen concentrator. It was a way of concentrating oxygen through a power supply. The heater failed. The baby got more and more cold, short of oxygen, developed respiratory distress, and then died before the power came on. So this is truly an everyday event, and in this particular hospital, they told me every time the power goes out, they lose 2, 3, 4 babies. Okay, so just that single event of the power going out. There's another way to look at the same story, which really is the essence of the quality process that we promote, which is to look at it through a systems lens. So this is exactly the same story, which has a beginning and it has an end. The beginning is that the mother was admitted after 20 hours. I don't need to tell you that there's a whole story in there about access, about delay in access, decision-making to get to the unit. A mother who came in after 20 hours then is subjected to another 8 hours. There's a failure here, as is evidenced by the fact that the baby was asphyxiated when it came out. So there's a systems failure here. The baby, this is the successful part. The baby is successfully resuscitated and transferred to a nursery. On the other hand, I have another picture, which I'm not showing here, which is the same nursery with 7 mothers looking in through a window at a row of babies on a bench, okay? And this is because they were not able to fit into the kangaroo mother care unit. So there is a kangaroo care mother unit in this hospital, but it was full. And so all these babies out, and I can guarantee you that the babies who were in kangaroo mother care survived, and the babies who were in cots died. And even because we know that these babies are highly vulnerable, and so on. So there is a for each one of these events there is a narrative that has a beginning and an end, many steps in between, which are all subject to an improvement step, all subject to measurement, and this is the essence of how we do improvement. So we are pummeled, and I, as a practicing physician, I was overwhelmed by the fact that everything had a guideline. But the issue is not what to do. We've known what to do forever. It's really how to do it. And I think this, even in the age of all of these health systems interventions, this question is still paramount. So we have plenty of evidence-based subject matter knowledge, all the protocols in the world, the guidelines, and some very good standards now coming out of the WHO, which I'll show you in a second. We also have increasing implementation knowledge. One of the work that I was involved with the reproductive health team was to really try to pull apart what's the consensus of the must-have health system interventions that are required to put this evidence-based subject matter into good effect. And there is, I don't have to go through this, but this will not be a surprise to you. The real advantage of going through an exercise like this is that it gets rid of some of the proprietary favorite acronym-driven ways of implementing improvement. It really says what are the things that are really needed in order to activate. The WHO has produced for maternal newborn care a combination of excellent evidence-based practices, which they're known for, but the real step forward now is that there is more and more knowledge emerging around what are the health system components that are required to move from evidence to action. And really gratifying is that there is more and more attention now to the standards that cover experience of care. The issue, though, is that even with all of that knowledge, we still haven't answered the question of how. And so this is what Deming really gave us, which is to say that if you want to change the performance of a system, you really need a very systematic way to bring the evidence-based subject matter knowledge together, and now the growing implementation knowledge together. It's not enough to just name the parts. And this is one of the big, I think, criticisms of the WHO building blocks, is it really was very input-driven. So the question is, how do you change the performance of the system? And Deming said there were four really key things that you need. First of all, everyone has to be on the same page about what the system looks like. I gave you the example of the mother coming in and the baby dying and the steps in between. Secondly, change is hard. There is a whole field of psychology that has to be understood and applied in a systematic way to change a system. We have to understand data. We understand, and he referenced data variation, but certainly data over time as opposed to before and after, really important, and the theory of knowledge. So if we look at psychology, we're trying to push the system away from the status quo, away from a blame culture, away from a command and control towards a much more enabling, highly motivational culture, which focuses on adult learning and creativity, and understands that there's some people who are going to take this on right at the beginning, and then there are going to be some people who are going to stand in our way, and we have to become experts on psychology. We have to understand, simplify a complex system. That story I told you, there are many, every clinical interaction has a beginning and an end and many steps in between, and we need to use that. But very importantly, we need to use the ideas at the front line. Understanding data is the third, very importantly, because we are often reacting to a seesaw of today is good, tomorrow is bad, instead of understanding that data has a natural pattern, and then to be able to understand when things really do change. And then finally, the learning system. And I think that this is the part that is mostly left out. We talk about the plan, do, study, act cycle, and that's become the mantra, I suppose, and that's what quality improvement is most associated with. But really what we're talking about is soliciting ideas and then testing them, working in teams and building knowledge at every level of the system in a very systematic way. So psychology, a common system, understanding variation, and the theory of knowledge. The second big topic that I wanted to discuss was around the integration of quality and the movement, really, from an old style, command and control style, to a more enabling modern style. The current state in many of the places that I work in is a very strong command and control, lots of rules, regulations that are coming from the capital city, a strong quality assurance, and quality assurance, by quality assurance I mean an external inspection, intermittent external inspection to see how things are going and then reacting to that, often reacting to say things should get better. And then an emerging quality improvement movement, mostly competing. I hear a lot of talk about, is it quality assurance or is it quality improvement? What's better? What's the advantage of command and control? So we already have from industry a much better way of organizing quality, which is Joran gave us the trilogy, which is an integrated way of looking at quality planning, improvement, and control. I just want to give you a brief example of how he illustrated this. So the quality planning is the starting point, which is the amalgamation of all the knowledge, the designs, the best designs, and a theory, a prediction of how the system might be best designed going forward. So in this case, a system was designed to operate at around a 40% performance. This is the zone of control, and in a well monitored system, you would keep an eye on how things are going. The next thing you would notice is that the system falls a little bit out of control, and here we use a zone of improvement, which is if you have standard work, it often is just simply the application of the standard work that will allow you to get back into control. However, you cannot drive this system up to a new level of performance without a new design for the system. This is where quality improvement comes in, the rapid cycle testing, taking us up to the new zone of control, which now can be monitored. All of this, of course, feeding back into better designs for quality planning. I want to give you an example from the field. I was involved in work that tried to get mothers who were in labor prematurely, who needed to get corticosteroids to rapidly mature the lungs of their babies so the babies wouldn't get respiratory distress. So a very simple example of screening the mothers, putting them on treatment, and making sure that the right mothers got the treatment. So here's the percent of mothers who got the steroids. You can see before we started, almost nothing happening. Everybody gets it after the first week because this is Hawthorne. Everyone's watching, everyone's excited. Next week, you're now down because the system hasn't really changed. We see the system improving. We're now reaching our goal. In a good quality control system, somebody has observed that the system is no longer working to its current performance. So standard work is applied and it goes back. Something more critical happens here because it doesn't go back to the standards, and that typically is a change in staff, somebody or the fact that the standard work hasn't been fully applied. So you've got a zone of improvement, a zone of control, but nobody here somebody's paying attention, and here no one's paying attention. This is the very sort of simple rubric. The difference between how this happens and how most systems that I observe are conducted is that all of this is happening within the unit. So the people who are charged with the responsibility of taking care of their patients are keeping an eye on their own data rather than being externally inspected and being told that they're not working up to scratch. So we now have these three components of quality: planning, control, and improvement, all of which require a learning system to inform them. I'm going to finish off with a brief reference to scalability. We have developed a scale-up framework, really, which is based on much work that's done by others, many of whom are in this room, which really provides a very systematic way of looking at an exponential sequence for scale-up. And it really gets to the heart of engaging deeply with the ministries of health that we work with before setting out on one of these activities. One of the big breakthroughs really is this idea that there is a unit of scale, and it's usually at the level of the district or the sub-district, where things can get worked out on a fairly small scale before you go off trying to scale them up. Even when you think you've got it sorted in a pilot or a prototype model, you do need to make sure that it's working in different contexts before going to full scale. The beauty about the system is that you can really move very rapidly from 1 to 5 units to start off with to multiple districts to get to the whole country. And we're now in several countries using this methodology and demonstrating that you can get very rapidly to full scale. I think it's really important to also understand that the methods that we apply at each step of the way are really quite different. A lot of emphasis on innovation during this time, a lot of emphasis on context adaptation in the testing in different context phase, and then a lot of application of standard work when you're moving very rapidly to full scale. I think I just wanted to use my last 5 minutes to talk about a real example, which is our work in South Africa. So South Africa currently has a 1.5% transmission rate from mother to child. It's one of the only programs that I know of where the public healthcare system has achieved a level of performance that is better than the randomized controlled trial that set up the evidence. So the randomized controlled trials, the initial randomized controlled trials for PMTCT showed that you could get a transmission rate down from about 30% if you did nothing, down to about 2% if you applied a full-scale treatment. And this public government-run health system currently has an average transmission rate of 1.5%. So how did they do this? And I think just watching the path of the South African AIDS program is very illustrative. So in 2000, there was an international AIDS conference where there was a street demonstration demanding that the South African government pay attention to the growing epidemic. They resisted initially, but in 2002, the program was launched, and then the new advances in dual therapy came through. The government then got really serious about launching a health systems intervention in 2008, setting a time-bound goal, and then the president finally got involved and addressed the state of the problem on World's AIDS Day. So you can see progressive acceleration of a combination of policy, new protocols, new very key health systems intervention, and then increasing role of leadership. I just want to talk about the health systems intervention that we were closely involved with. So this again started as a learning demonstration in 3 districts. This is the rate of testing of mothers coming into the clinic, pregnant mothers, to get them tested for HIV. And you can see we were able to learn from one district that was already doing really well and find out in the other 2 districts how to get performance up to an acceptable level, which would be over 90%. Over time, the government then took this on, asked for demonstrations to show that this could work in a number of other contexts. This only took a further 9 months, and then the government completely took the program on completely independently and then ran it with the results that we have described. Here is the public reported DHIS system that is now reporting the antenatal clients initiated on antiretrovirals. So you can see just on 100% of those mothers are now receiving antiretrovirals, which is why the transmission rates are unbelievably low. This is a multi-step process. It's over time, it's complicated, yet every one of these steps is being undertaken at about a 98% level. My final comment really is about is around sustainability. This is the model that I encounter all over Africa. There is a effective intervention that is run by an NGO that is already pretty far along. Okay, the national ownership and support of the intervention comes in at this stage. They've already been working back here. The NGOs have been working sometimes with the districts back here, but the national government and the programming only gets involved really late. What that means is that you often have to go back to the beginning in order to be able to get it scaled up across the country. This is the ideal model of ownership, setting up engagement with the ministry right at the very beginning, deep regional support as well, and then the external support which can drop off. Typically now in our 2 most recent national programming, the entire escalation part of the program is run by the host country without any support. I think I've used up my time, but thank you for your attention.